Standard 5 is clearly the biggest. It's the most comprehensive amongst our strengthened standards, and there are significant clinical care requirements to address from this standard. We have a big role to play here. The background to this standard is that it was actually developed by the Australian Commission on Safety and Quality in Healthcare. So that's the hospital regulator. They've written the NSQH standard, so for acute care. So why have we got the acute care regulator that normally regulates hospitals helping us with standard 5 for aged care? If we rewind, this actually comes from the final report into the Royal Commission, which encouraged that actually this Australian Commission on Safety and Quality in Healthcare be given the responsibility to write the whole of the aged care standards. That didn't happen. It wasn't unanimous in the recommendation, but they did take standard 5, the clinical care standard, and develop that in partnership with the Aged Care Quality and Safety Commission. So what does that mean? There is a very genuine expectation in this standard to improve the clinical care of older people. And if you can see the small blue box down the bottom here, and you might have seen in the news I think it went live last Tuesday, that we now also have a psychotropic medicines for people with cognitive disability or impairment as a clinical care standard that again was written by the Australian Commission on Safety and Quality in Healthcare. I've included this one. It's a really valuable resource. If you haven't had a chance to look at it, I encourage you to do so. But what this means is that the acute care regulator is getting more and more involved in the regulation and standard setting in aged care, so we can only expect the rigour of standard 5 to continue. This is what my gap analysis looks like. It's full of red, it's full of orange, and I have been joking to our team in the office that if I was an L&D coordinator, look out, we would be doing standard 5 education for months and months and months. I cannot stress the significance of the need for clinical care education. But where do we focus on? With so many requirements, how do we know, what to address? And we want to focus on preventing harm. Keep it simple. Let's try and prevent harm. Good clinical care education can reduce harm, and this is what improves care. My key point, why I honestly say hands on heart, why there is this need is because I'm an ICU nurse, and I've seen the flip side of older adults with multiple chronic comorbidities that have really acutely deteriorated. They've become seriously unwell. They've perhaps had a preventable hospitalization and often experience preventable harm and sometimes death. And let me tell you, being on the other side where that older adult ends up, I tried very, very hard to provide that person with a dignified death. But getting to hospital and being in a stark, bright, white intensive care unit is very different to the comfort of a home, to a residential environment where we can provide a comfortable, dignified death. So that is why this really matters. Good clinical care education can reduce harm, and for an older person, that segue of events, that pathway of deterioration is very rapid and does not end well. So that's our role. We want to try and prevent that. That's what standard 5 is telling us. So as I mentioned, how do I approach that? I'm just going to take my word for it. I want to actually provide you with the clinical evidence based for each of the elements. So each of the outcomes, 1, 2, 3, 4, 5, and 6 for standard 5. As you can see, this is sort of the template slide that I'll use. And at the top, you've got the summary of the clinical evidence base, which I'll talk about for each slide. But then and I won't call this out every single time, but I draw your attention to the role of the education and the target audience. So this is how I'm trying to make it as practical as possible for you to think about for this particular aspect of standard 5. What's the key role of education? And what would my target audience be? So who are the people in my organization that might benefit most from this? Now, of course, you've all got different contexts of practice. You've all got different settings. You know, we need to take all of this and apply it to our organizations. But I've tried to, as I said, summarize and give you the why behind the need for education and a little bit of guidance practically about how you can use that. But I do really recommend that, of course, you use your own gap analysis results and assessment to understand, you know, what you're doing specifically. But if we start with a 5.1, clinical governance, with your target audience, you're looking at executive leadership, your governing body members, and maybe your facility managers or, you know, RNs. So we're not talking about it for everyone, but the underlying clinical evidence base for clinical governance is that accountability drives quality care. Good governance is vital for effective implementation of all other standards. And particularly when we're working with an unregulated care workforce. Our registered and enrolled nurses have very strict CPD requirements. We've got our May 31st deadline coming up in a couple of weeks where we have to demonstrate in order to remain registered that we've done the minimum amount of continuing professional development and documented it. But our care workforce isn't registered. So good clinical governance is particularly important to help us set and identify those scope of practice boundaries, which reduces risk. I'll just add that all of the references will be sent with the slide. So I've got a long reference list. I won't, I won't sort of specifically call out each reference or each paper that I've used for this, but we'll send the slides out and they're there. Moving on to 5.2, preventing and controlling infections in a clinical care environment. This is simple. We've all got the lived experience over the last 4 to 5 years to know that good hand hygiene prevents harm. If we can't prevent harm from happening and an infection does occur, then of course they need to be managed effectively. And that's where our appropriate antimicrobial stewardship comes into play. We want to prevent that resistance. We want to keep our antibiotics working as well as possible. So think about the role of education as being quite practical in nature for your clinical staff. You know, we want hand hygiene, we want good aseptic technique when we're cleaning wounds, and keep perhaps that antimicrobial stewardship and that invasive line management, so an indwelling catheter, tracheostomy, peg tube, so forth. Keep that education up your hand for your senior clinical staff that are actually, managing those devices. 5.3 is our safe and quality use of medicines. Now, this is just a snippet, of course, of the clinical evidence base for why we need good education to prevent harm. And that is very simple. Medicines, what are they? When they're in a little tablet form or a liquid that's been compounded and formulated nicely with TGA approval, they are medicines. But let's not forget, before that happens, they're a drug, they're poisons, and they have serious risks associated with them. So preventable harm, education needs to address the documentation of allergies. We want to be thinking about how do we understand, prevent, and respond to adverse drug reactions. Polypharmacy is clearly a huge topic for our context of practice, and you'll see in a minute the inappropriate use of antipsychotics and antibiotics are defined as a really big risk that we want to mitigate through education when it comes to the quality use of medicines. I want to highlight a key point here though, and that's medicines education only goes 50% of the way. Very clearly in the audit documentation, so the evidence mapping framework is a clear, very clear call to ensure that there are also those effective systems and processes within your organisation that support the implementation of good education. And particularly when we're working with our care workforce alongside our clinical, our RN workforce, is the need to verify scope of practice. So I've taken this specific line directly from the evidence mapping framework, and it says your organisation must have processes to define and verify the scope of clinical practice for prescribing, dispensing, and administering medicines for relevant clinicians. So education goes part of the way. Make sure that that aligns with your good systems and processes to ensure that we do have the safe and quality use of medicines. Next point is that clinical care really has never been more relevant. This is a research article that came out about 2 weeks ago. So just before the psychotropic clinical care standard was released last week, the week before we had this journal article be released in the British Medical Journal. So very high quality literature review. And it was a large study. There were 35,000 older people, so over 50, with dementia. I know that definition's a bit hard for some of us to get our head of. I'm just saying that's what the study criteria was. Don't read into it too much. But in all seriousness, what the results of this study showed was that antipsychotic use was associated with increased risk of all outcomes, including stroke, VTE, so that's venous thromboembolism, myocardial infarction, that's a heart attack, heart failure, fractures, pneumonia, and acute kidney injury. So it really does provide new insights into the risks associated with antipsychotics in people with dementia. And I can't stress enough that there is now very good quality evidence that demonstrates the incidence of serious adverse outcomes associated with these medicines in people with dementia. So we need good education, good quality education to prevent harm in this group of people. Again, more evidence for the need for good education on clinical care, in particular the safe and quality use of medicines. This was the latest sector report. So it was data from July to September last year. Medication management was the #1 complaint topic in residential care. So a very high risk area for us to look at carefully how we will address it. The next big one is standard 5.4, comprehensive care. And I know people can find comprehensive care, it's big, but I think what exactly is it? And I encourage you to think about 4 topics to address here within comprehensive care. And they're the words highlighted on your screen here. So we've got assessment, documentation, communication, and deterioration. Why do these matter? So coordinated care, good quality care has to be underpinned by good assessment, right? We need to be able to understand what's an older person experiencing right now. We change shifts. At the end of 8 hours, we've got someone else coming into that role. So we need clear documentation. Not everyone reads the progress notes. You might have a new electronic medical record system. We have language barriers. So of course, communication is the glue that holds that together. And so if we have good assessment, good documentation, excellent communication, what does that enable us? It enables us to recognize and respond to deterioration, and that's what prevents harm and can save lives. So if you think about comprehensive care, boil it down to those 4 things, I think that helps, take the standard and actually think, all right, I get how I can, apply this standard in practice. And so this is our bread and butter, assessment, documentation, communication, and I'm in our Melbourne office at the moment, and we've just wrapped up filming another course on deterioration. So absolutely critical. We've got an extensive library of modules on these topics, as you can see in front of you. Again, evidence for good quality clinical care, you just got to go straight to our evidence mapping document. So, that is the document that the auditors will need to use in order to demonstrate, that an organisation is meeting that standard. So for 5.5, there's a very clear message that an organisation is actively addressing these core clinical risks. So what you can see here is provider level and service level evidence that auditors will be looking at collecting. And the key question that they will be asking you and your organisations is, how do you ensure that workers are trained to identify, monitor, and respond to clinical risks? You will be asked to provide evidence. That will be a specific focus of audits, is your response to that question. They have listed the core clinical risks. You can see that's a screenshot right from that evidence mapping document. So within 5.5, we're now going to go through briefly those core clinical risks and demonstrate how we can relate education to those areas. So if we start with choking and swallowing, there is very, very good evidence for education that looks at preventing choking and swallowing. Why? Because a choking and swallowing incident can lead to irreversible brain damage because we've got a lack of cerebral oxygenation occurring. We also have a huge risk of aspiration pneumonia, which is an acute lung infection associated with a choking or a swallowing incident. So there is significant risk associated with eating and drinking and medication administration in many of our older people. And that risk is because of the actual assessed and documented or the potential risk of dysphagia in older adults. But we also have some physiological changes that occur with age. We've got reduced saliva production, and many medications, like anyone that's on a Parkinson's medication or a benzodiazepine, they have additional reduced saliva, dry mouth as a result of those medicines. So for this topic, we not only want good systems and processes in place that captures a person with dysphagia, but we want targeted education. And I do recommend that to your clinical and care staff that are involved in that mealtime experience to really address this core risk. And you can see some of the AusMed modules that we have on this topic. The next is continence. And I think it's a really important, point to say there is very strong clinical evidence that preempting a person's toileting needs reduces the risk of harm and increases quality of life. And that's because there's this, what we call a high impact sequelae of events, that if we have reduced mobility, just think in your mind how many of your residents and people in your care meet at least one of these points: reduced mobility, impaired cognition, under or malnutrition, medication side effect, skin integrity or some type of skin breakdown, and frailty. That sequence of events, I call a ticking time bomb. Honestly, just think how many residents, meet those, tick those boxes. So that when we have all of those things put together in the setting of residential aged care in particular, but also home care, we can see a huge cascade of harm occur. The other evidence-based to draw on is the relationship between skin integrity and continence, which I'm sure is familiar to many of you, but we have a very, very, high cost of wound care if we have a wound establish and then break down as a result of incontinence-associated dermatitis. So this all begins with good toileting. We can prevent this sequence of events, by putting good toileting and good continence assessment and management strategies in place. And again, that starts with education for the right target audience, of course. So investing in education here can reduce your costs of harm elsewhere. Good continence education can reduce your risk of falls. Good continence education can reduce your risk of wound breakdown. So, it's an important one, not just to tick the box, but to get right. Moving on to falls and mobility, we know falls are, of course, a significant cause of potential harm, and across, the acute aged community care sectors, they're known as obviously a high priority because of there's such a high burden of disease, there's such a high cost associated with falls. Even though we know that education improves care, it can reduce risks, there's still evidence that, good falls prevention education isn't being put in place. So I encourage you to just look at targeted education. Look at your stats, be guided by your falls rates, be guided by, what documentation is being presented, and then going quickly with education. So, you might have a general need for falls education, but then you're seeing some rates of higher falls or near misses in certain areas. Use education wisely to address it in a targeted way, and that means, good collaboration with your quality teams as well. The next core clinical risk that falls within 5.5 is nutrition and hydration. Now, we've obviously got standard 6, the new one on nutrition, so I'll cover this more in a couple of minutes, but I do want to just highlight, the need to not overlook hydration. Our fluid status or dehydration is directly linked to our risk of pressure injuries and is a leading factor in UTIs, urinary tract infections causing. There's a lot of integration of risks associated with clinical issues. So, and it's because dehydration can, affect our cell turgor. If you think of, when you're dehydration, you've got something called a snuff box here between your thumb and your index finger. If you push that, when you're dehydrated, there's not a lot of turgor in your skin. And then if you think of the older people in your care and you go and shake their hand and say, how you going? How, feel their hands, often dehydrated. So we're still seeing dehydration in older adults, but education is a powerful vehicle for resolving this. But you put that with the previous slide on safe swallowing and choking. Clearly, we need education to make sure that our staff understand the risks associated with drinking a particular fluid in a particular person, and they don't just hear the message, hydrate, hydrate, hydrate. So, the more we talk about it, the more there is to really get right. It's non-trivial, the amount of clinical risks in older people, particularly when we've got chronic comorbidities, we've got frailty, we've got dehydration. There's a lot to manage. When it comes to mental health, I guess I'll just use this as a quick opportunity to say that from a training perspective, I guess it's an opportunity to incorporate a couple of core topics with mental health. So you can see, we've got a module on cultural safety in mental health or trauma and mental health. Mental health is such a big topic. We could have a whole other webinar on mental health, but use some of these AusMed modules wisely to think about, how can I reduce the risk of mental health deterioration? So we're talking particularly, depression, anxiety in an older adult, in a culturally safe, trauma-informed, healing-informed way. And so there's some, really, really great, well-made modules that can support you with that. Oral health, again, we know this is particularly important, not just for our quality of life, but for our general health. And in our population, older adults are less able to self-manage their oral health. So, good education aimed at our care staff that are primarily involved in this particular area of care is critical. Pain management. I mean, anyone that's had pain, it's awful. Acute pain, chronic pain, acute on chronic pain. We're talking about a complex topic. And, I think it's really important to emphasize that for this particular topic, we do need different modules to target our different target audience based on the complexity of that role. So we've got different, different duration modules, different types of modules. You might have an 8-minute brief article, or, our pain management course is, I think, about 45 or 50 minutes. And I'd be aiming that at your registered staff. So, clinicians, registered nurses, enrolled nurses, and your care staff, we all play a really critical role in identifying, assessing, and managing pain, but understand the way that this is done in your organisation and the different scopes, so that you can then identify what education, what module might be most relevant to the various target audiences. All right, pressure injuries and wounds. I think every time I teach this topic, I'm sorry for the very visual image here, but I remember the really bad wounds that I've seen. I worked in oncology, hematology, palliative care, neuro, ICU, and I've seen some bad wounds over time that should have been prevented. The cost of managing these is incredible. The cost to the person, if you've ever been with a person with a fungating wound, so that's a wound that smells, you can see, you can feel, you can hear the impact that wound has on that person's sense of self and quality of life. Wounds aren't just costly in terms of dollars, but they really can impact a person's sense of self. You overlay that to an older adult who's already, grieving, feeling a sense of loss, transitioning to a new environment, has a form of cognitive decline. Adding a wound onto that, pain when they're unable to communicate, it's a lot to our most vulnerable. So we really, really want good prevention strategies, good documentation that aims at minimizing a person's risk, because early recognition of an early pressure injury and preventing that deterioration, that even hospitalization or that unnecessary and costly wound care, really does reduce harm. So if you're looking at, how you can go about addressing this particular requirement, I'd probably split it up into your prevention and your management, and perhaps look at a training module that focuses on prevention to your care staff, and that more in-depth management, so your wound selection for, some of your clinical staff. If you know this, if you know the importance of good pressure injury prevention through education, look away now. I give you permission, look away now, full disclaimer, but this is what good wound care education looks like. We stop bad stage 4 full thickness tissue loss from occurring. That is what good wound education looks like. That's the worst of the slides. So I'll swiftly move on, but it is important. Once you see that, you can't unsee it, and that image will stick with you. All right, sensory impairment. This is clearly a huge topic. It's the last of the, the final component of 5.5. So we're nearly towards the end of standard 5. But, I think, something I want to highlight when it comes to sensory and cognitive impairment is, I really urge you are leaders in your organisation in a really quite a powerful position, where you can make decisions about what education you're gonna invest in. When it comes to dementia, delirium, behavioural disturbance, cognitive impairment, I really encourage you to think about how we can help someone understand the importance of having a person's unmet needs met. I'll kind of unpack that a little bit. If we can understand, or if through education we can help others understand, that often basic unmet needs of an older adult with cognitive impairment can be that cause of deterioration and acute behavioural deterioration, we can totally, reshape the way that we support people with dementia. So, thinking about that, if we understand, what are the core needs that an older person has, and if we can work out for each person in a person-centered approach how we can identify and respond to those basic needs, then we can often minimize situations that may precipitate changes in behavior and those difficult changes. So invest in, really core basic education. There's some great modules that we have on it that help us look at dementia and delirium in a different way, a person-centered way. What are the needs of the person in this situation, rather than, an immediate response to a deteriorating behavior? So there are many, many more high-risk clinical needs. The good news is that there are many AusMed modules available to help you reduce this and address these requirements. Clinical care is our bread and butter. We actually, many of you may know this, but we started as a publishing company. Our founder, Cynthia, is a nurse, and she wrote the first book on the first AusMed book on managing urinary incontinence in the older adult. So clinical care, and particularly in aged care, has been our bread and butter. So I really encourage you to explore the library if you've got access to it, and really look at, the huge variety. I haven't even mentioned the word diabetes. And you think about the risks associated with a hypoglycemic episode. So the risk of insulin, the risk of asthma. We haven't covered anything to do with stroke, chest pain. There is a lot of clinical risks out there, and I encourage you to look at your organisations, your gap analysis, and identify if there are some risks within your organisation that you might like to look at mitigating through education with our modules.